Hello, my name is Dr. James Rubenstein. I'm from the University of California, San Francisco. I'm here at the ASCO meeting in Chicago 2019. Yesterday, I gave an educational session on the role of consolidation options in primary central nervous system lymphoma, a variant of non-Hodgkin's lymphoma which is associated with a very poor prognosis and whose incidence is increasing in older patients. So one of the key questions in this field is the role of consolidation after induction therapy. We know that induction therapy using methotrexate containing regimens are very effective in cytoreduction and improving performance status, but they have a deficiency in terms of eradication of minimal residual disease. So one of the key questions in the field is, what is the best consolidation option? Traditionally, whole brain radiotherapy has been the mainstay after methotrexate-based induction, but with greater experience, there's increasing recognition of the long-term neurotoxicity associated with whole brain radiotherapy, as well as insufficient long-term survival associated with radiation used after methotrexate. So in the last 2 years, there's been a completion of 2 major randomized phase 2 trials which have evaluated the option of high-dose chemotherapy and autologous stem cell transplant as a potential consolidation for after induction in primary CNS lymphoma. First study that was published 2 years ago in Lancet Hematology, the IALSG 32, evaluated newly diagnosed primary CNS lymphoma patients that received 3 different induction regimens. In the second randomization, they were randomized to receive either whole brain radiotherapy at a dose of 36 gray with a potential 9 gray boost in patients with a partial response, versus autologous stem cell transplant with a preparative regimen consisting of BCNU and thiotepa. Thiotepa both being a very effective CNS penetrant alkylating agent, which is a favored chemotherapy drug used in preparative regimens for this disease. The results of the trial showed equivalency between BCNU thiotepa autologous stem cell transplant and whole brain radiotherapy in terms of 2-year progression-free survival, which was the primary endpoint for this analysis. Moreover, they also showed, however, that patients that received whole brain radiotherapy, not surprisingly, showed long-term neuro-cognitive deficits which were persisted over 2 years, whereas those patients that received autologous stem cell transplant showed improvement in memory and quality of life, so that, thus favoring autologous stem cell transplant as a potential consolidation regimen for patients. And this is evaluated patients aged less than 65, a relatively young cohort for a disease whose incidence is increasing among those aged 65 and older. The second study, which was published in Journal of Clinical Oncology earlier this year, was the Percy study, which is a French randomized phase 2 study, which evaluated the same principle of whole brain radiotherapy versus autologous stem cell transplant using a different consolidation regimen consisting of TBC, the drugs being thiotepa, busulfan, and Cytoxan, which is a relatively aggressive preparative regimen used for autologous stem cell transplant and is associated with perhaps more toxicity than BCNU thiotepa. However, their results showed evidence of improved event-free survival at 2 years in those patients that received autologous stem cell transplant compared to whole brain radiotherapy. And they confirmed, using many of the same neurocognitive inventory tests, that the deficit associated with whole brain radiotherapy in terms of memory and executive function compared to a patient that received autologous stem cell transplant who showed improvement in those domains. So in summary, there are 2 major randomized phase 2 trials which have been published in the last 2 years, which both showing equivalency or superiority of autologous stem cell transplant in terms of event-free survival, but improved characteristics in terms of neurocognitive endpoints in the patients that received autologous stem cell transplant versus whole brain radiotherapy. Third option, which I discussed, is some of our own work using a non-myeloablative consolidation approach, which is also very aggressive and requires hospitalization of about 18 to 25 days, which consists of a chemotherapy regimen known as EA, or etoposide plus twice a day high-dose Ara-C. And we piloted this analysis in a phase 2 trial called CLGB 50202, which was published a few years ago. We showed patients that received EA consolidation had a 2-year event-free survival of 77%, which is very consistent with what is seen with autologous stem cell transplant. And the results of this trial were the basis of a trial that was recently completed accrual a few years ago, 2 years ago, called CLGB Alliance 51101, which is the first trial to evaluate 2 different non-radiation containing consolidation approaches, randomized patients after upfront methotrexate, temozolomide, rituximab to receive either EA consolidation, etoposide Ara-C, versus autologous stem cell transplant with BCNU Thiotepa. So we await the results of that trial once enough events have been documented. Another option which I discussed was the important problem of the aging population in primary CNS lymphoma. As I said earlier, patients, we're seeing more and more patients age 65 and older who are not good candidates for either whole brain radiation or autologous stem cell transplant. So what do we do with those patients? So I discussed some of our own work in a recent phase 1 trial we completed, published in Blood Advances last year, in which we demonstrated that lenalidomide at doses 10 milligrams or higher penetrates the CSF reproducibly in patients and achieves therapeutic efficacy in the phase 1 trial. And we also demonstrated that patients that had received lenalidomide after receipt of genotoxic therapy, either focal radiation or repeat administration of chemotherapy, showed longer remissions than they had in after prior chemotherapeutic interventions without lenalidomide. So this is the basis for a experience we've applied to older patients and recently published in the British Journal of Hematology, in which we evaluated low-dose lenalidomide maintenance after upfront MTR, methotrexate, temozolomide, rituximab induction, and we showed very encouraging evidence for long-term remissions in patients, and we also demonstrated that low-dose lenalidomide is tolerable in this patient population. So this is an area which I think merits further study in an important population which has been neglected and who are not good candidates for brain radiation or autologous stem cell transplant.